Well, it's terrific to be back here again at this wonderful course. So let me go ahead here and get started with the debate. I only have 8 minutes, I think, so I've got to make every second count. As far as disclosures that are relevant, numerous relationships with companies that make antithrombotics, largely research funding to Brigham and Women's Hospital. So there's been a lot of controversy about aspirin. This is a perspective piece that just came out in Lancet in about the past 10 days or so, the rise and fall of aspirin in primary prevention is what it's called. And I think that's where a lot of the controversy is, but at least in the lay media, it has spilled over to secondary prevention. I don't know if it's happened to you, but I've got patients that are calling in about aspirin in secondary prevention, wondering whether they should still be on it. But you know, the controversy is really with primary prevention, where early trials, such as the Physicians' Health Study, certainly indicated that there was a reduction in non-fatal MI with aspirin. More contemporary trials, it's a bit more mixed, though. I think it has to do with what endpoints you look at and which populations you look at. Ascend, for example, was a positive trial in diabetic patients with aspirin for primary prevention, but the way it was portrayed in the presentation and paper was as a negative one. This also is a recent paper, just came out in JACC in the past week, a meta-analysis of aspirin for primary prevention, and I like the figure that we came up with in this, which just weighs the safety and efficacy of aspirin. And it's not, even in primary prevention, such a simple story. Yes, it's true that if you look at efficacy and safety and ischemic events and overall bleeding events, they're pretty similar in terms of number needed to treat and number needed to harm. But that's not an entirely fair way of looking at things, because an ischemic stroke doesn't actually equal a GI bleed, at least in my opinion. Yes, either can be bad, but fatality from GI bleed is relatively low. Disability or death from ischemic stroke is not uncommon. Now, obviously, intracranial bleeding is a different story. So, you know, myself, I believe in just adding up sort of irreversible sort of events, MI, ischemic stroke, obviously cardiovascular death, and weighing it against fatal and intracranial bleeding. You know, other forms of bleeding are certainly bad. You don't want it, but shouldn't really be weighed the same. But at any rate, whatever controversy exists is in the primary prevention setting. Dr. Levine nicely reviewed the data with respect to dual versus triple therapy, and this meta-analysis supports the fact that an approach of double therapy, double antithrombotic therapy, in the setting of atrial fibrillation and PCI or ACS is associated with a significant reduction, about a halving in the rate of major bleeding, lower intracranial hemorrhage as well, and at least overall, no obvious increase in ischemic or thromboembolic complications. Can I say that for sure in patients who've undergone complex stenting procedures? Can I say that for sure in patients who've got high CHA2DS2-VASc? No, you know, those patient-level meta-analyses haven't been done to date, but at least at a trial level, it does appear that a strategy of double therapy is better than triple, and dropping aspirin is a good idea, I'd say right after hospital discharge, certainly not more than a month after. So primary prevention, the setting of AFib, PCI, I'm all for it, you know, debate aspirin. But in secondary prevention, I don't think aspirin's going anywhere. And specifically, what this debate points to, patients who've got a drug-eluting stent, I don't think we can drop aspirin yet. Global Leaders, fantastic study, published in The Lancet. It was a complex design. It was a good trial, great investigators, but a very complex design that I think makes interpretation a bit more challenging. First off, it's a 15,000 plus all-comer PCI population. That's good, large number, large generalizability, randomization, but it's an open label design, and I think for these sorts of important questions, that's a limitation. All sorts of biases can creep in. Compounding that, there were two different strategies that were tested, actually multiple different strategies. So in the experimental arm in ACS patients or those with stable CAD, got a month of dual antiplatelet therapy, and then aspirin was dropped and ticagrelor 90 BID was continued. So a good way of testing that particular strategy of a month of DAPT and then ticagrelor monotherapy. But in the control arm, it was different treatments, where if the patient was an ACS patient, well, then they got aspirin and a year of ticagrelor 90 BID. And if it was stable CAD, they still got aspirin for the duration, but then clopidogrel for a year. So there's a difference between clopidogrel and ticagrelor. There's a difference in terms of durations of the P2Y12 inhibitor. So a very complex design where if it's open label, I think it makes it extremely hard to interpret unless it's a total knockout win for the experimental strategy, which it was not. the primary endpoint, good endpoint, all-cause death, MI, was not significantly different between the arms. Yes, the experimental arm is lower, and the p-value of 0.07, 0.05, 0.07, it's a bit arbitrary. It's not that I necessarily worship at the altar of p-values, but in an open-label trial with multiple different arms and comparisons, to me, that's not good enough to change practice. Is it provocative? If you look at different ways of analyzing the data, subgroups, there are some signals of positivity for ticagrelor as the anchor arm there, but not good enough to change practice. And in the editorial to Global Leaders, I concluded that aspirin is still the global leader in antiplatelet therapy. It's cheap, it's familiar, and therefore I don't think it's going anywhere anytime soon. But I keep an open mind. Dr. Moran is leading the TWILIGHT study, and in this debate, maybe she knows something about the study I don't, but assuming that the results aren't known, this study is an important one, but we shouldn't change practice till it's done. It's looking at a 3-month DAPT and then drop the aspirin strategy. I think it makes sense. I already do that in patients that are at very high bleeding risk, but whether we should do that as a routine really needs to wait until this study. It'd be premature to change strategies without the data. Dr. Levine nicely reviewed this important trial, also published in The Lancet, and I'm not sure everything in The Lancet always gets the fair attention it should in the US, but globally, it's one of the world's leading medical journals, and the impact of smart data, I think, should be quite profound. It showed, as he illustrated with KM curves, but didn't actually verbalize, a 5-fold excess in myocardial infarction. It was a hazard ratio of 5 in patients who stopped their DAPT at 6 months. So for sure, in the ACS patient, who in general is at higher ischemic risk, longer durations of DAPT, at least 12 months, are indicated. But of course, you have to use common sense. If they're at high bleeding risk, even there, the duration may need to be abbreviated. So that's antiplatelets, but the antithrombotic world is complex. Things are changing all the time. The combinations of antiplatelets and anticoagulants have been studied, such as in the COMPASS trial, with very low-dose rivaroxaban added to aspirin versus rivaroxaban at a medium dose alone versus aspirin alone. And there, the combination of very low-dose rivaroxaban plus aspirin won. It beat rivaroxaban alone, and it beat aspirin alone, too. Now, you might say, oh, so that's a loss for aspirin. No, it's still a victory for aspirin because the winning arm still contains aspirin. So even with this new exciting therapy, which is not specifically for stented patients, but those with high ischemic risk and stable CAD and or PAD, the winning arm still has aspirin. That's not to say we can't do better than aspirin. As some of you might be aware, even aspirin is undergoing all sorts of evaluation. There's some theoretical concerns. This is from a small 40-patient crossover study showing that the enteric coating on aspirin, which is the most common form of aspirin used in the US, might interfere with its ability to exert its full antiplatelet effect. So-called aspirin resistance, to use that term that was in vogue a while back. So there are attempts to make better aspirins that are better absorbed, that still have reasonable GI safety. And we'll see if any of these come to light, but it's just to say that research on aspirin isn't dead yet either. So to conclude then, I think that aspirin is still the global leader in secondary prevention, in part due to the fact that it's cheap, it's very familiar to physicians throughout the world, so I don't think it's going anywhere. DAPT is still indicated for at least a year for the reasons Dr. Lean outlined in his talk in ACS patients. So none of these other debates in primary prevention or AFib or even low-risk stented patients should contaminate that line of thinking. Aspirin primary prevention, that we could debate for an hour. AFib and PCI double therapy clearly has less bleeding than triple therapy, and I think should be the standard of care as of yesterday, for sure in patients that are high bleeding risk, but I would say in all patients. There's this new role of aspirin plus low-dose anticoagulation. If that COMPASS regimen really gains traction, which with a mortality benefit I think it should, that anchors aspirin still in the secondary prevention universe for long-term therapy. For these reasons and many others, I don't think aspirin is going away from clinical practice for sure in the DS patient anytime soon. But as I mentioned, I always keep an open mind to new data, and we'll see what Dr. Moran tells us about the TWILIGHT trial, though I don't think she's going to tell us about that today. Thank you very much for your attention.